good. And you're ignoring the conflict. This is still a lose-lose situation. Competing and coercing, you're forcing them and pushing one desired outcome over another. This is a win-lose. The manager gets his way, the employee doesn't. Cooperating and accommodating. So one person gives up what they want so that the other can receive what they're asking for. Win-lose. Compromising or negotiating. Each party gives up something. So this results in a double win-lose, win-lose. And collaborating, both parties set aside their original individual goal and work together for a new common goal. This is a win-win. Okay? What they ask of you is, one, what kind of resolution is happening when they describe the scenario? You need to know, are they smoothing? Are they compromising? Are they collaborating? Right? Are they avoiding? You should be able to phrase the situation based on what's happening. And the other thing is this a win-win, a win-lose, or a lose-lose situation? That's what they like to ask. Yes?
What about the win-yield? Because there was a dynamic quizzing question too about it, and win-yield.
It doesn't say on here, but a win-yield, I think the best thing would probably be the compromising, where one person gives up there, like they don't do anything on it, they don't move. So yield implies that you didn't push or move or go back. You yielded, you just gave up. Right?
The rationale for that one was about that both parties decided to allow management to make the decision and they accepted whatever the outcome was.
I'll look into it. I know what you're talking about, and I've seen the win-yield before, but I thought they just
Like, that's how I explained
it's no longer
it, the
here.
rationale. So I was still kind of confused on it.
Yield should be a situation like you're saying where you give up, like you don't move on it anymore. You just let it be. So no, you didn't lose or win per se. Or one person won, win yield, the other person just let it go. They didn't lose, but they didn't win either. They just let it be.
Yeah, cause I remember that question, it was like, they both didn't wanna take care of a certain person or something like that, so they said, let management just pick who out of us two is gonna get to it.
Right. And so one won,
Yeah.
and one yielded. Just take the action. It should be.
It's kind of like win-lose though, right?
Yeah, that's why I thought they got rid of the win yield. It might just not be a current thing.
I think it's because they already accept
The
that
decision.
loss before the loss.
Right. They'll say they don't move on it, they're just gonna let it
Right,
be.
right.
I'd be shocked if you did see another win yield, but just take it as one person just lets it be. Just let it go. But they didn't come out with the worst outcome per se. Okay, it gives you examples down below. Please read them over. It can provide insight for you to answer your questions. Okay? There's one more thing to cover on this chapter. The critical pathway here. No, it's in another chapter. For cost-effective care, this basically is a way to start telling us now how to not waste the hospital's money. Right, don't overuse supplies, only get what you need. You just answer that, right? You're not spending your time, you're not talking to people outside of it. We'll go over critical pathways in a different chapter, which in short is most hospitals for common infections and problems have an already established set of orders. Meaning like a person comes in or they develop a serious infection within the hospital, we already have a set guideline. They're gonna take antibiotics, a specific one for 7 days. They're gonna do X treatment for this, like they're supposed to leave by the 9th day. And should they go over or outside of that critical pathway, there's an investigation. Like why is this person developing more issues or more sick? It shouldn't be that. It's already set what we do. Make sense? So if he comes in for a STEMI, non-STEMI, something else, then there's a plan, there's a pathway. Make sense? Alright. Chapter 2. Coordinating clinic care. For chapter 1, I'll tell you what's relevant for myself, just to like recap, and what you may see in my test. 1, delegation. That little table of what you can give or assign to an AP or a PM. And the other is time management. What should we do or not do to save time? Leadership styles, examples of this, and conflict resolution. And again, they give you examples of what it looks like. Let's start off with case management. We go down just a little bit, right before critical pathways. And in short, it's the nursing role in case management, okay? So principles of it are, right, like, it could be a nurse, case managers are usually nurses or social workers. It could be some other healthcare personnel, but generally it's a nurse or a social worker. If you haven't seen it before, a case manager can have like several patients. We're gonna say out of 30 patients, there's 3 case managers, each one has 10. And so their goal is like, what's gonna happen with this patient? Like, what's the plan here? Like, they're the ones overseeing, developing the plan and guiding as to what resources can come in and out. So in long-term care, this is a little bit different compared to hospital. So for example, in hospitals, the case manager is like, okay, so the patient fell, broke his arm, what's gonna happen? Are we just gonna treat that here, pain, cast it up, send them home? No, they need physical therapy. Okay, so do they need in-house therapy? Could it be from home health? Could it be from, where are they going? Are they gonna go outpatient? So the case manager will set up what's gonna happen next. Do we need to bring in a dietitian? Do we need to send them out? Are they gonna go home? Are they gonna be transferred to a facility? Do we need higher level of care? Where are we going? And the case manager will make the phone calls and set up this transition to guide the patient as to what's gonna happen. Long-term care, right? Is the diet okay right now? Is anything changing or needed that's going on? And so they work with the family and or patient to develop a plan of care. What's gonna happen, what's the goal here? This varies from long-term to acute care in the hospital, yes.
So does every patient get assigned a case manager, or it depends?
Generally, yes. In a facility and how it should be, they each have a case manager or a social worker assigned to them. This is less seen and more behind the scenes in convalescent and SNFs because the patients are there long-term. They usually have weekly or monthly meetings to see what's going on. At home, especially in home health, because they need someone to like what's happening.
It's more common in hospitals.
It is more common in hospitals, it's more active in hospitals. Because every day, the doctor is like, what are we doing? Like, you can't just sit here, like, what's gonna happen next? So it's more active in hospitals, but it's still happening in SNFs and home health and hospices. They all have case managers, something needs to happen. Yeah. So nurse or social worker or healthcare professional. So social workers, for example, they generally don't have medical experience, but they can learn. And there, it doesn't mention it on here, but at least in LA, I know for sure, I don't know about all of California, they have licensed clinical social workers. These are people who are trained with medical background and are more aware of disease and disease process and have more clinical training of what happens afterwards. What do we do? Yeah. So they're better guided for it. And they're not know-it-alls, they consult with the doctor, the nurses, the family, the patient. What are we doing? What do we need to do? They're the middleman. So, right, I want my mom sent to Irvine. Like, where, right? It's like, I want them there, so then they call the hospital, can you receive them, this and that, set up transport. Doctor, can they transport, are they critical, or they consult with everybody as to what's gonna happen. That's case management. Okay, so again, nursing role, coordinate care, as we just said, facilitate the continuity of care so they can organize to what happens next, enhancing the quality of care, limit unnecessary costs and lengthy stays, so their job is to move them forward. Okay, and critical pathways is next. Critical pathway, a critical or clinical pathway or care map can be used to support the implementation of clinical guidelines and protocols. Guidelines and protocols are basically set rules or plans that you just have to follow. These tools are usually based on cost and length of stay, mandated by prospective payment systems, Medicare and insurance companies. Case managers often initiate the critical pathway, but they are used by many members of the care team. Critical pathways are often specific to a diagnosis and typical length of stay. When a client requires treatment other than what is required, or a longer length of stay, it is documented as a variance, along with the information of why the variance occurred. So 2 key points. What is a critical pathway? Set guidelines and care protocol. It's a specific type of treatment, and you know what's gonna happen with this person, or what should be done. The second is a variance. So they'll ask you, even the critical pathway, now they're delayed, they're gonna stay longer, you should document, or what is occurring, a variance. Yes? You have to know that anything that occurred that now makes them stay longer or need higher care, that's a variance. Because it's now not part of the plan. This was never supposed to happen. They were supposed to get treated for this, go home on the 7th day. Why are they not going home? What happened? And so you gotta document the variance. That's the variance. There's something that happened, and now the patient requires a longer stay. Now, this is, like it says, a thing, and if you caught it, these are parameters mandated by payment systems, AKA insurance. So insurances don't want to just dish out money, right? Hence, too much fraud. Came in for diarrhea, why are you still in the hospital? Make sense? Like, why are they there? Should have been dealt with, antibiotics, go home. Why are we paying for this person to be in your hospital? So, oftentimes, if a patient has a certain diagnosis, certain specific problems, and they fall out of the critical pathway, the insurance is like, nope, I'm not paying, that's your responsibility. You're doing something that's making the patient require more care. Hospital's responsible for this, not me. We paid you for the treatment. You're now just adding more. So that's the purpose of it. All you need to know is set rules, guidelines for diagnosis. Anything outside of that, variance. Good? Okay. Continuity of care, referrals, transfers, and discharge planning. So for this, the nurse's role, what I want you to really emphasize here is the discharge and handoff reports. Okay? We all know patients are gonna transfer, they're gonna discharge, they're gonna go to another facility, they're gonna change shift, you need to give a report. Okay? Handoff or change of shift report. It's always a big thing of being asked, what do you need to tell, what do you need to give, what do you need to say? Okay. Perform what the nurse was assuming responsibility for the client's care. Describes the current status, reports the next shift of pertinent care information, provides the oncoming nurse the opportunity to ask questions. Should be given in a private area, conference room, or at the bedside if there is no one else there or they have privacy. This should not be done in the hallway or at the nursing station. That's where they get you. That's where you're doing it. It's like, they'll be like, gave handoff report in the hallway at the room or something. It's wrong, because of the fact that you did it in a public space, okay? So either do it in a conference room or at the bedside. What do you tell people? I think they kinda got rid of some listings, but I'll tell you a few. Basically, anything abnormal. Shouldn't ever be routine. You don't tell them the routine. I gave them all their meds this morning. Like, I know. What you should tell me is if you didn't. Because I know you're giving them their med. I'll see their med list. I know they're taking it. What I need to be informed is, did you skip any today? Because I am automatically assuming, it's safe to assume they're getting their meds. The only thing abnormal is when a patient is refusing, or not taking them, or not needing them. Why did you not give it to them? You refused. His blood pressure was too low. Now I'm aware that there is something different happening than the normal. Any incidents, refusal, pain management, any PRN medication that you did give. So not the routine, but the PRN, as needed. Why did they need, right, that medication? Something's different, that's what you're reporting, the abnormal. Client's vitals are stable, irrelevant, I would assume that. Except though, you do report the abnormal value. His respiratory rate was higher today. They're getting a low-grade fever, blood pressure's lowering. Right, we give the abnormal. Yes, the shift will change. Report to the provider. Here, you have to have your assessment ready. You do give all this information. Your vitals, client's condition, your request, like do you have any recommendation of what should happen? And or clarifying a prescription. Transfers. If you're gonna transfer the patient, this is more comprehensive, right? It's not a change of shift report. Now you're looking at their medical diagnosis, their current doctors, demographics, their health status, what are we doing with them, what's the plan of care, do they need rehab there, enteral feeding, specific diets, okay? Allergies, we said diet and activity, any equipment, they use a wheelchair, right? They walk, they ambulate, they need a bedside commode, they require oxygen, they're currently at 2 liters. You need to be comprehensive about everything that they do or need to be done, so that the hospital can be prepared, or the receiving end can be prepared. I'll tell you, we can't take that patient, right? Patient is on TB, airborne isolation, we don't have a negative pressure room, we can't take the patient. Make sense? They need to be aware of everything. The patient has an infection, I don't have isolation rooms, period. I can't receive the patient. They can't be isolated. So you tell them everything that's going on essentially in the transfer. Yes. Back to the case manager. Hence that's what your case manager is there for. A facility said, and hopefully you're not in a situation where they accepted them and now they can. If that's not a scenario that will ever come up here, but in case of anything like that, yeah, back to the case manager. Hey, I called, ACC can't receive the patient, or XYZ, and they gotta figure out what's the next step. Okay? Discharge planning. Gotta make sure they have everything ready. Home health, their equipment, almost the same deal. The difference that I want you to see here about discharge is the last bullet point right above discharge instructions. It says a client who leaves AMA. And that stands for right against medical advice. A client who leaves without a prescription for the discharge is leaving AMA. Legally, a client who is legally competent and has the legal right to leave the facility at any time. The nurse should immediately notify the provider, so you tell the doctor, right? If the client is at risk for harm, it is imperative that the nurse explains the risk involved in leaving. The individual should sign a form relinquishing all responsibility that can arise from discontinuing prescribed care. In documents of communication, you told them, this is the risk, these are the situations, sign here. And if they do not want to sign, you just document that they didn't want to sign and they left. Okay? A nurse who tries to prevent the client from leaving the facility can face legal charges of assault, battery, and false imprisonment. Now, you can't hold anybody against their will. Non-specific to this, but to entertain the question, it's like, I guess by what it sounds like, if people would know about it, yeah, because of the IV drug use. If you could leave, no one's gonna physically grab you, but they're gonna probably call the cops. Yeah, they're gonna, because they have to report it, like, hey, a patient left with a peripheral IV. Yeah, and that's why I always document, and that's the thing they would teach you, when we discharge a patient, like home or not to another facility, I document always that I remove the peripheral IV. I always document they remove, like, 'cause we see where it's at. So I say remove peripheral IV, size, like specific, and where it was at. So I say that I removed it, and then, what time, and that they tolerated it well. Catheters intact, nothing was left inside. So you should always. But can people leave? Sure, no one's gonna restrain you, or should, because then it becomes a problem. But, so it's weird, and it is, here it's like, that's what I'm saying, it's gonna be one of the things that's, they're not gonna try to like trick you, it's either they are leaving AMA or they're not. Now, for real life, and just to give you guys perspective, it does happen, and I just tell patients sign here, and again, yeah, I remove, right, like, you want me to remove that, and sign here, everything. The worst one in a situation, the crappiest I've probably been in, was this lady had a thing, I didn't know the type. But apparently her first day in the hospital is pretty chill, but as the 24 hours approach, she goes confused, crazy. And she then levels out after a few days. And we didn't know that. And the son, I didn't know this either, had a stroke, and he couldn't even talk to me. So he was saying like weird things. And that was her point of contact. He's like, call my brother, my other brother. He's like, I'm sorry. He's like, I'm disabled. And he would like make like weird noises. I said, what's wrong with him? So then I called the brother, and the brother then clarified, like, he has a stroke and has a speech impairment because of it. He's like, but that's who lives with her in the state. He's like, I'm out of state. And then I'm like, well, your mom's trying to leave, and he tried to like calm her down over the phone. This lady's leaving and like trying to get up off the bed, and I call a doctor. He's like, I was like, can we get restraints? He's like, get a sitter. I said, we don't have, we don't have it. I was like, I can't get a sitter. She's getting up. She's leaving. I said, do you want to order out? I was just like, it's later at least. And he's like, no. And he's like, actually, I will order it. This dude orders a pill. And I was like, all right. So then I gave it to her. She dead ass did this. She does it a cup, looked at me, lost it. And I'm like, why would he order that? Like, it's obviously supposed to be injected. So then whatever. And I called him again, like, dude, she's leaving. And he's like, don't let her leave. And I'm like, so do you want to order restraints? He's like, no. He's like, it's not necessary to restrain her. And I was like, but she's leaving. He's like, don't let her. I was like, I'm not gonna hold her. And he's like, okay. He's like, I'm coming up. I was like, what do you? He's like, don't let her leave. I was like, I'm not gonna hold her down. Like, that puts me in a situation. But he didn't want to order. You see what I mean? He orders restraints because she's confused. No problem, I restrain her. You don't wanna order restraints? What do you do? I'm gonna watch her leave, but I'm not doing it. What else do you want me to do? So like doctors need to be a little bit more, you know, conscious of what's happening, like. And so he comes up and he's talking to her and I'm like, what do you wanna do here? So anyway, that was a crappy situation of, what do you do? Like, you don't know what to do. Anyway. Discharge instructions. Make sure that when they say what to go over in the thing, step-by-step instructions for care they need at home, and describe any procedures that they should be performing at home. You should give opportunity that they return demonstrate. So if they're gonna inject insulin, check their blood glucose, things like that, they should show you that they can do it. And you document that. Medication regimen, okay, for home. How to take their meds, which meds, how, and what to look out for. Precautions, again, for their method, what should they know? And adverse effects. Names and numbers of their doctors and community services for the diagnosis. And plans for follow-up care, when's their next appointment. All this needs to go home with them or have been told to them before they leave. To prevent any further harm. Yes? Alright. It's 11:33.